So emergency services, first we'll do emergency services, then we'll go to operation theater, and if at all time permits, we'll also brush up towards through the ICU. Okay, so we'll start with emergency services. It's in page number 217, DC Joshi textbook. So the meaning of emergency department. Emergency department of a hospital means a part of a hospital to which a person injured in road traffic accidents or those suffering from some serious complications are taken care of for urgent treatment. Okay, so I have made it bold in word, urgent treatment. Okay, emergency department works round the clock, and whereas in the previous class we had a discussion on OT on outpatient department. Okay, so that's a difference there. When a question comes, okay, a question can be formed like that: which of the following department works round the clock? Is it outpatient department or emergency department? In an outpatient department, in the definition itself, we have seen the department works on scheduled hours. Okay, but emergency department works round the clock. So such kind of questions may be formed, so you should be clear with your concepts. Okay, so emergency department works round the clock. Immediate diagnosis is done here, and urgent treatment is provided for illness of emergency, for the illnesses which are in emergency of nature and injured from any road traffic accidents, etc. So that's the meaning of emergency department. Okay, page number and book etc is given in the first message of the chat box. Please go through the chat once. Then the definition as such, you don't have to by heart it. Again, I'm saying the same thing. Don't by heart the definition, just understand the concept of it. That's enough. So emergency has been defined as a condition determined clinically or considered by the patient or his relative or any representative. They consider it as requiring an immediate medical, dental, or any allied services should be provided immediately. Failing which may result in the loss of life, limb, or any function, or motor function, or sensory function. Okay, so that's the definition of an emergency in terms of healthcare. So what are the functions of emergency department? The first and the main function is to provide immediate life-saving medical care to all the people who are admitted in the emergency department. Immediate and life-saving medical care has to be provided. To provide any emotional support to the patient or his relatives. That comes secondarily. The first main priority here is to saving the life of an endangered patient. To take care of a medical legal aspect, all the emergency cases especially in the emergency department, the medical officers and the doctors have to be very vigilant about which cases come under the medical legal act. For example, if it's a road traffic accident, a gunshot wound, okay, any poisoning cases, okay, any abuse cases, any alleged sexual abuse cases, etc. Okay, so they have to be very vigilant about the cases they are dealing with. Those cases has to be recorded in front of a police officer. If the police officer is not present, then the chief medical officer can put the case under a medical legal aspect after providing the treatment, because treatment has to be provided even if it's a medical legal case or not. Treatment has to be provided. Okay, but if a police officer is not present at the scene, the chief medical officer or the in charge of the emergency department can consider certain cases as medical legal, and then after providing the treatment, after saving the life of the patient, it can be proceeded along with the law enforcement. Okay, so treatment is given the first priority even in medical legal cases. Communication with the media in case of any disaster management, etc. So the chief of the emergency department is concerned with media communication, handling out some signs of these other people who are injured. Any relatives who is watching the news, please come forward, we require blood, or anything like that. So any communication with the media is done through the emergency department in certain cases, not in all cases. Education and training and research. If at all it's a medical education institute, then education and training is also provided here. to transport the services both intramural and extramural, okay, from outside, or you are referring the patient from your hospital to another hospital. And intramural, after providing emergency care, initial care, you transfer the patient either to any ICU or inpatient department, okay, so that becomes intramural. So these are the certain important functions provided by the emergency department. Then you have types of emergency, okay. Surgeons have classified emergencies into following categories. The first is the first emergency, the care which must be done within the first few minutes or an hour. There is a golden hour rule. Those who are in the medical professional, they must be knowing the golden hour rule. Whatever care or treatment you give to your patient, to a critical patient, in the first hour, as soon as they reach the hospital, what treatment you're giving in the first 1 hour decides the follow-ups and everything, okay. So that's the first emergency, the treatment which you give in the first few minutes or within the 1 hour of the admission. Then you come to second emergency, that is what must be done within the next 6 hours, okay. Should we move the patient to ICU? Should the patient the patient is stable enough, critical observation is not required? Should we move them into an IP department, inpatient department, or the patient is stable enough, home care can be given? Should we discharge the patient from the emergency itself? So that such kind of decisions are taken in the second emergency. And third emergency, what must be done within 24 hours? For example, certain in primary health centers or in primary healthcare settings, okay, certain high risk cases cannot be catered. The hospital doesn't have sufficient equipments or resources to cater for certain high risk cases. So in that condition, what they will do, they will suggest the patient party to keep the patient in the emergency department for a continuous observation of 24 hours, or move the patient to the existing ICU in that hospital for a continuous observation of 24 hours. Then we can refer the patient to a tertiary care center or any other higher level care centers, okay. So that is also the services provided by the emergency department. So these categories are defined on the basis of time required, okay. The decisions which you take in the first 1 hour, that is first emergency, 6 hours is second, and within 24 hours, that is third emergency. Then types of emergency services. First is the major emergency services, like in road traffic accident and etc. And multiple system injuries are there, multiple organ failures are there. In such cases, a primary health setting cannot handle. So those will be transferred to a teaching hospital or a medical institute, a higher education hospital or any tertiary care hospital. So these kind of major emergency services are provided by teaching and training hospitals. Then you have basic emergency services. It is provided in all the hospitals. You have seen the 24/7 signage in most of the ER and trauma centers. Okay, so those come under the basic emergency services. The basic ER department, which all the healthcare facilities have. Okay, the hospitals, especially the hospitals have. Then you have standby ER. Usually in a primary healthcare setup, where the patient cannot be treated here even under emergency condition or in inpatient condition. The patient, you have very limited resources to treat the patient, and very well that a referral is required. So you you don't discharge the patient back to their home. You keep them under observation in your institute in a standby mode, so that a proper referral is given, and from an ambulance you can directly direct the patient to a referral center. So that is standby ER. Then you have referral emergency centers. The first aid is given and then referred to appropriate emergency centers. It is very similar to standby. Okay. For example, some sub clinics. Okay, the private clinics which run in a small town, etc. Those come under the referral emergency services. So these are the types of emergency services and the types of emergency. It's there on page number 217 to 218. Just read through it. Then we come to the physical facilities which is provided in the emergency. Okay, so if we can divide the emergency department into patient care area, clinical area, administrative area, and circulation area. One image is given in page number 219. Just read that image, understand that image. Questions may come from that image. Okay, which which facilities will come under which area. Okay, so be thorough with the names of these areas, how we classify it. Mostly in the outpatient department also it's same, the patient area, administrative area is similar, but depending upon the questions, okay, we can change some wordings here and there, so you should be very vigilant about that. So in patient area, the trolley bay is there, the reception is there where you register the patient. Okay, in some hospitals, waiting areas and VIP room will be there. The patient area is a space for security, staff, police, ambulance drivers, attendants, etc. There will be a small coffee or snack bar if it is possible. Pharmacy, a small pharmacy will be there. So those things come under the patient area. And the clinical area is where the treatment and the diagnosis is done. Okay, so whatever are the aspects of treatment and diagnosis, those functions will be done under the clinical area. So trauma room, examination room, triage area, you determine the severity of the cases and you categorize them accordingly in the triage area. And staff will work in this clinical area. Nursing station is also present in the clinical area, and emergency ward with adequate number of bed, all the beds and everything is present in the clinical area. Administrative area, usually it's the office of the CMO, the chief medical officer, or the medical officer on duty. Okay, their rooms will be in the administrative area. Sometimes in some hospitals, a medical superintendent's room will also be adjacent to the chief medical officer's room. So depends upon the architecture of the hospital. So understand, in the administrative area, it will be that you will not have direct, the patient parties and the patient will not have direct access to the administrative area, only the staffs may have. And the PRO, public relation officers, the assistant public relation officers, those rooms and those offices will be under the administrative area. Then comes the circulation area, all the corridors, the staircase, lifts, trolley bays, everything will come under the circulation area, wherever a patient movement takes place, patient party, visitors and staff movement takes place. Okay, that comes under the circulation area. Next we'll come to the staffing. Okay, staffing is in page number 221. The topics before that we have already discussed. The clinical area, administrative area, just go through that. Whatever is given in that image, it is again repeated in the pages. Okay, and equipments also you can just go through that. Equipments, a basic checklist can be made through the equipment list, which is given again in page number 221. Just go through that, read through the equipments. The people who are from non-medical background may not have much understanding of it, so that's why we are not stressing on that area much, but just for your knowledge and understanding, you can go through, you can familiarize yourself with certain names of the equipments. These equipments will be repeated in the further classes in ICU, in OT. Some of these equipments will be repeated. Okay, so staffing, manpower in an emergency department mainly consists of the physicians, surgeons, the medical officers on duty, pediatricians, anesthesiologists, and interns if it's educational institute, interns, residents, nurses, everyone. Okay, and in nursing staff, full-time nursing staff under the able guidance of a qualified and trained nurse is the backbone of a emergency department. Most probably the students who have done specialization in emergency and trauma care, okay, those students are posted under the nursing facility. That's why now we require specialization even after doing BSc nursing. Some certain diploma specializations are required so that you can choose your career accordingly. So you are not being put as a float nurse who just roams here and there from one department to another. You can specialize yourself. Your skill improvement can be done when you take such diploma courses. Okay, so trauma care and emergency care nurses will be posted here. Paramedical staff, the ECG technicians, OT technicians, physiotherapists, lab technicians, radiographers, all those will come under the paramedical staff. Group D and Group C staff are the housekeeping staff, the security, okay, the ward boys, those come under the Group D and Group C staff. Just read through the drivers, ambulance drivers, everyone. Okay, read through the examples given there in the staffing section. And ambulances, every emergency department must have a very good backup of ambulance service. So when it comes to ambulance services, all the life support equipment, including defibrillator, monitor, ventilator support system, must be remaining in a working order. That means regular and daily maintenance has to be ensured. Daily, you have to check at least 2 times. So the nurses who are responsible for the ambulances, the drivers who are responsible for the ambulances, they should on a daily basis, at least 2 times, they should check the functioning of all the critical life-saving machines like defibrillator, monitor, ventilator support system, etc. Okay, so daily maintenance has to be done for this. It is not only the movement of the patient with speed, but with safety also. Not just you are no, not just it's not the responsibility of the ambulance driver just to make sure the patient reaches on time, but the patient has to reach on time. Along with that, they have to reach safely also, so to prevent any road traffic accident or do not get involved in any road traffic accidents. The team must be well trained to use the materials and equipments of the ambulance while transporting the patient. The driver, the paramedical staff, the nurses, and in some cases, when you are moving the patient from into a referral system or a tertiary care center, which is much far away, hours away from the smaller institute, usually a doctor will also, the emergency care doctor will also follow them towards their referral center. Okay, it depends upon the policies of the hospital whom should be sent along with the patient and the patient party to the referral centers. Most of the time it's an ambulance driver along with the paramedical staff, but if it's a critical condition where continuous observation is required, a trained doctor will also be available. A critical care doctor will also be available in the ambulance. So this is the team of a driver. Even the drivers of the ambulance are given basic life support training, and advanced life support training is provided to the drivers of the ambulance also. So this team must be well trained to use the materials, equipment of the ambulance while transporting the patients. Then policies which you have to be very careful about when it comes to the emergency department. So when you are looking at the management aspect of the emergency department, these are the topics that are very important. Okay, so record maintenance, especially when it comes to medical legal cases, medical legal records has to be maintained. In some hospitals, they have a policy that all the MLC case files will be stored for a lifetime. In some hospitals, they will follow that only they will store the medical legal case files till the case is settled. Okay, as soon as the case is settled, whatever punishment or whatever decision the court has taken, okay, post which you can discard the medical legal files. Some hospitals may follow that protocol also. Okay, so but in both the cases, you should be very vigilant about the record keeping of all the medical legal cases. And referral policies. Two kinds of referrals can take place from the emergency department. One is, the most common one is, you refer the patients to a higher medical facilities, okay, with a much better medical training and equipments present. Okay, and the second referral takes place where you send them to a lower center for after discharging them directly from the emergency department, you send them to a lower center like some primary healthcare center or something, so that how along with domiciliary care, along with home care, they can do treatment and follow-ups in their township or in the region itself. Okay, so these are the two types of referrals that take place in emergency department. Then you have medical legal cases. It is mandatory to start the treatment as soon as the case comes in. Do not wait till the police to arrive, because you will be putting your patient's life at risk in such cases. So when a dying declaration is done in the emergency department, a magistrate should be informed. The magistrate who is available, he or she should be informed. But if it may take time for the magistrate to reach the hospital, then the treating doctor is responsible to record their dying declaration. Okay, so even the same applies even in case of a medical legal case where a police officer is involved. You do not have to wait till the police officer to arrive. The treating officer, the emergency officer on duty, the doctor who is on duty, can take the initiative to be the team leader to handle the case. And as soon as the treatment is given, as when the law enforcement is involved, he can transfer the case to the law enforcement. And then we have disaster preparedness. When it comes to any disaster management, emergency department is at the forefront along with the medical records department. These two departments are at the forefront. So they should have a very well planned and well rehearsed disaster preparedness plan going on. Monthly mock drills, or at least 2 to 3 mock drills per year, has to be performed by the staffs of the emergency department. And they in the first step, what they have to do is the activation of a disaster management plan. Even the duty officer who is present in the emergency department, he or she is also authorized to activate the disaster management plan. As soon as the disaster management plan is activated, the patients who are currently undergoing the treatment in the emergency department, they will be moved to another department, because now the emergency department becomes the triage area where people who are affected by certain disasters will be brought in. Triage has to be done there in different categories. In some hospitals, there is only a triage system of 3 colors. In some, they will go for 4 colors: green, yellow, red, black. Okay, the people who have lost their life, they will be under the black triage. The people who are stable, the patients who are stable, they will be under green triage. Okay, some will use orange, some will use yellow. Okay, it depends upon the hospital's policy. So emergency department becomes the triage area when it comes to a disaster management plan. Then you have code blue procedure. Code blue procedure is same for all the departments, even in emergency department. Okay, as soon as the code blue is announced, every day there will be a team who will be ready with the cardiac trolley, who will be the in charge of the cardiac trolley. They have to rush to the bed number, because when you announce the code blue, you should be very clear with what bed number. Okay, you can't just say code blue emergency department. Okay, you can't say that. You have to be very clear with the bed number 4, code blue, because when they rush to the emergency department with the cardiac trolley, they should not be asking around which patient where to go. Okay, so when you announce the code blue, be specific about the room number or bed number or patient number. Okay, what is the policies of the hospital? Do not miss that particular information. And then medical audit. So medical audit is an important tool for evaluation of emergency services. The following things should be ascertained in a medical audit. So first thing is completeness and adequacy of the and accuracy of the records. It should be complete. All the medical files which you send to the MRD, it should be complete. Otherwise, it will come back from the MRD, medical records department. It will be sent back. And correctness and substantiation of the diagnosis. The ICD protocol, the international coding of diseases and everything, what ICD coding your hospital is using, it should be correct. The medical files from the ER department should be correct to that ICD coding. Then errors in diagnosis and management. That's a negative mark in the quality control. Okay. When you're misdiagnosing a disease in the emergency department and mismanaging the disease, okay, that has a backlog when it comes to the quality control. The cases of complications, how you are handling the cases of complications, how many referrals per month you are providing, and how many like critical care complications, how many multiple organ complications is your department handling. Cases of death, in the death certificate also, the reason of death, the cause of death, these should be specifically mentioned. Doctors are trained for writing all these reasons and cause of death, etc. The difference between all these areas. So death certificate should be complete when you are issuing a death certificate from the emergency department. And then quality of the record maintenance, it should be on time, accurate, and complete. Investigations which could be avoided or were indicated could not be done, everything has to be mentioned. So these comes under the areas of medical audit. Grievance redressal system, again the same like in what we have discussed in the OP department. There should be a mechanism of grievance redressal in your hospital, and it should readdress the grievances of the patients, visitors, and Consumer Protection Act. Under the Consumer Protection Act and under the Right to Information Act, the grievance redressal system should be set up in the hospital. A person of appropriate status must be designated as a public information officer. Usually it's the PRO, public relation officer, will be taking care of the grievance redressal system from the emergency department. Thank you. Any doubts? So the next topic is Operation Theatre, page number 249. So an OT, operation room, or a surgery suite is a room within the hospital within which surgical operations are carried out. Okay, you can understand the meaning of it. The surgical suite is an entire surgical facility, including the operation room, hallways, workrooms, storage, fronter, desk, everything. Okay, from the front desk to the biomedical waste department, especially for the OT, all these areas together, it is called a surgical suite. So, aims of planning one operation theater in a hospital. Okay, the first aim is to provide a high degree of asepsis, make sure infection control is on point. Next is ensure maximum safety to the patients and the staff working in the OT. OTs are high risk areas for any hospital acquired infection or healthcare acquired infection. So maximum safety to the patient as well as the staff. Ensure maximum utilization of the ODT. OT. Okay, I by mistake I have put D here. Okay, maximum utilization of OT means when, for example, your hospital has 3 operating rooms. Okay, the administration has to make sure that surgeries are the elective surgeries as well as the emergency surgeries. Okay, in emergency surgeries you have very less of an administrative control, but when it comes to elective surgery, maximum utilization means none of the operating rooms should be left unused even for a day. Okay, because these OTs also come under the profit centers of a hospital, because surgeons have their own quotations for the surgery which they perform. Okay, so OTs are an areas of OTs is not a cost center, but it's a profit center for a hospital. So maximum utilization ensures that your hospital is in the profit line through an OT. An OT should not become the line of loss. So when it comes to elective surgery, administrative control can be done to ensure that at least one operation every day is done in all the 3 OTs. One OT you can keep it for an emergency operation theater. The other 2 OTs can be kept for elective surgeries, and accordingly the surgeries has to be planned so that maximum utilization of the OT is also done, so that your hospital keeps making profit from this department. Ensure maximum comfort to the surgical team, considering long hours of work in difficult posture. Because if it's a long standing surgery, without moving, the OT staff have to be in such a difficult posture, the dexterity and all has to be maintained in a surgery. So the OT environment should be very comfortable. The floors should be anti-slippery, etc. We'll see about the environmental aspect of OTs later. So maximum comfort to the surgical team who is doing the procedure, so that they the room is not putting extra additional task on them on top of the task which they are already performing. To provide complete environmental control with respect to the air pressure, the air quality, HEPA filters, etc., which is used. Okay, and regular swabs of the air condition and everything has to be sent, so that OTs are not a place where infection is being born and it is spread. Flexibility of uses of operating suites. Sometimes, for example, in some tertiary care hospitals, there are certain operation rooms which are completely booked for the use of ophthalmology, or there are certain OT blocks which are just for the neurosurgeries. Okay, and some OTs are there for the use for interdepartmental uses. Okay, so some, it is better to have a flexibility if you are not a specialized hospital. If you have a multi specialization, always have few OT blocks at hand where flexibility is involved. Okay, it is not classically for a particular department. Flexibility wherever it is involved, it's better. It's because it aids for any emergency surgery. Also, it aids for any profits. Next, the criteria of planning. Environmental criteria provide complete environmental control for the safety of patient as well as the staff working in the OT. How you can do it? Most of the OTs now, they have HEPA filter, air pressure which is controlled. Okay, air conditioning is done, controlling the temperature, what temperature should be ideal for the OT for performing certain procedures, etc. So those comes under the environmental criteria. Then we have an economic criteria, optimization of interrelationship between various financial areas and operating department. As I have explained in the flexibility of planning, when you're planning an OT, make sure if it is a tertiary care hospital you're planning, okay, there may be around 10 operating rooms. 6 of them are booked for a certain department. You can't perform GI operation in ophthalmology OT. Okay, so certain according to specialization, certain OTs are booked, but make sure you have made room for the flexibility of the OT also, where emergency as well as interdepartmental surgeries can take place. So that fulfills the economic criteria. Workflow criteria, the flow of patients, staff, supplies in the operating department should be well planned, because when when you are arranging a biomedical waste control room in an OT, it should not be somewhere in the front of the OT or somewhere in middle of the operating suites. It should be somewhere at last where patients or family members cannot access. Okay, it should be near the CSST or somewhere, or it should be at the very last area where you are not allowing your patients to pass through that particular room at any cost. Okay, so those are that is one aspect of a workflow criteria. Okay, because as soon as you enter, it should be the receiving area of the patients where pre-surgery examinations are done. Okay, next is the preparation room. Then you will go into the clean zone, sterile zone. There are certain zones. Okay, the zones also aids in the workflow criteria of the OT. Next, we have functional criteria. So design follows function is the golden rule. However you're designing your OT, it should not be just for the sake of ambience. Is your OT functional? Can people from the different departments in your hospital can function in this OT, in this suite, without causing hindrance to others? Okay, so function is given a priority more than design. Okay, design takes a second place here. Okay, you can have all high-tech equipments, all the latest advanced technology in your OT, but it is designed in such a way that it is generating a lot of internal traffic within the OT block. Okay, so having high-tech equipments doesn't serve the purpose there. Okay, even having a high-tech equipment, the basic thing of traffic control within the OT. Okay, scheduling the OT, the OT doesn't function on time. Okay, by 9 a.m. the certain OTs has to be functioning, but it is not functioning on time because of certain design criteria, mishaps, etc. Okay, so that will give a that will put your OT into a cost center, because you have invested so much capital in enhancing all the medical facilities and the look of your OT. But when it comes to the functionality of the OT, it's not as good as you have envisioned. Okay, so that puts OT into a cost center. So that's the functional criteria. Design will always follow function. That's the rule. Next is the physical facilities. The location of the OT. The best location of the OT is the one which permits a convenient and uncomplicated flow of patients, staff, and clean supply staff. Traffic has to be avoided. That is the goal here. It should be somewhere very close to the surgical wards and the ICU. Surgical wards or the post-operative wards. Convenient access to the elevators is therefore very essential. Orientation, northern orientation of the operation theater is considered to be the most suitable to ensure adequate daylight within the theater to avoid any glare. If the OT is present in a east or west kind of orientation, chances are usually when it comes to the environmental setting of a OT, you usually go for an OT where access of daylight is provided. But when you are providing access of daylight as much as possible, make sure the OT is present in the northern orientation and northern direction where glare is very less. If it is a east or west or somewhere, because of the rising sun, setting suns, glare may affect the functioning of the OT. Next, factors determining the total number of operation theaters which you may have in the hospital. For example, if it's about the type of the hospital, if it's a tertiary care hospital, you should have at least more than 10 to 15 OTs. In a secondary hospital, at least 5 OTs are okay. And if it's a very small hospital, so if it's a 100-bedded hospital, 2 OTs or 3 OTs are fine. Okay, so now how many OTs you require in a hospital depends upon what type of hospital it is. In some cases, if it's an eye hospital, all the setups required for an ophthalmological surgery setups should be available. So that's how the type of hospital determines what OT should be there. Hospital bed complements, there are certain standard rules which you follow. For example, like in some countries like Asian Pacific countries like Taiwan, Malaysia, Thailand and all, what rule they have is if there are 100 beds in a hospital, at least 2 OT should be there. Okay, and if there are 100 beds in a hospital, 5% of the beds should be ICU. Okay, so these are the certain bed complements which some countries follow. It's different from country to country, and also it differs from public and private sectors. Okay, the bed complements differ in that aspect also. The number and type of surgical patients you receive per year. You have started the hospital maybe 10 years back. The surgical patients which you had 10 years back were around 2,000 patients every year, but now your surgical patients are more than 5,000 patients per year. So what it determines here is 10 years back you just had 5 OTs, but now as your surgical patients have increased, you have to make some renovations and you have to add more OT complexes to your hospital. Okay, so that is how number and type of the surgical patients will determine this. And the number of type of surgical specialty, as I told earlier, if it's a tertiary care hospital, just imagine you have 10 OTs. 6 of them will be booked for a certain specialty. One is for exclusively for ortho patients. One is exclusively for neuro patients. Another will be for cardiac surgery. Okay, so depending upon the surgical specialties which you have in your hospital, number and types of surgeons. Okay, number of hospitals per day, similar to the number and type of surgical patients which you have. Average length of stay of surgical patients. Hospital policies. Some hospitals will have a policy that certain critical cases they can handle, but certain they will not operate at any cost. They will refer it to another hospital. Okay, so that comes under the hospital policies. Expected turnover interval of OT. Turnover interval means morning by 9 a.m. one operation was done. Then when is the second operation booked for that particular OT? Okay, so that is the turnover interval. Within 3 hours or 4 hours, will the OT be ready for the second operation? Okay, average size of an OT. What is the surface area? All those architectural specifications. Estimated cleaning time for the OT between surgeries. How long it will take for the scrub nurses and the housekeeping staff and everyone to prepare the OT to receive another patient. Allowance for emergency services, surgeries. Out of 10 operating blocks which you have, how many operating blocks have you exclusively put aside for emergency surgeries? Allowance for septic cases. Does your hospital take care of the septic case surgery within the same OT block, or do they have a separate OT block for the septic cases. In some cases, what happened is when you're doing a dirty surgery, for example, a surgery where it's a dirty wound, you have to do a surgery on a very contaminated kind of wound. In such cases, you will keep that surgery at the end of the day. You will not book those cases which is septic in nature. You will not book such cases in middle of the day and follow the same OT for another patient, because you will be putting the following cases to a risk of infection. So septic cases, either you should have a separate operation room, or you have to keep the septic cases at the last. That should be the last surgery performed in that OT room. Then the fogging and everything, complete disinfection and sterilization of the OT, it has to be done, and then only it can receive a new case. So those are the policies which you have to follow in case of septic cases. Allowance for staff breaks, the break times provided, etc. So these are the various factors which will define how many numbers of OT you should have in your hospital. So this is just a bird's eye view which usually takes place in India. If it's a 300 bedded hospital, at least the minimum you should have 3 OTs. Okay, 500 bedded hospital, at least 5 OTs. 750, at least 8 OTs, and if it's a 1000 bedded hospital, you should have at least 10 OTs. This is given in your textbook. This table is given. Size of an operating room. The size will depend upon the surgical facilities. Usually when you are performing an ophthalmological surgery, okay, the size of a ophthalmo OT is not as big as compared to what you will receive for a cardiac surgery or any neurosurgery. Okay, so size will depend upon the surgical facilities and the specialties involved. General operating room, usually it should be 40 square meter in area. Neurology, ortho, 60 square meter. See, depending on the specialty, the area will increase. Endoscopy suite and everything, the procedure room, only endoscopy is a very minor procedure. In that you can require just 20 square meter room. For OT, for 200 to 300 bed district hospital, optimum size is 18 by 18 to 18 by 20, but not more than 400 square feet. So these are the square feet. This is given in your textbook under the size of an operating room table heading in page number 250. Just go through that. Now zoning. Zoning, you have 4 main zones: protective zone, clean zone, sterile zone, and disposal zone. Okay, so not just the OT, the entire hospital works on a certain zone kind of category. Okay, so even within the OT, the zoning is quite important. So the first zone, protective zone, this is the entrance of the operation theater. The main facilities which lie in this area are patient's waiting area, reception, trolley bay, lifts, stairs, switch room, pre-anesthesia room, changing room, storeroom, etc. So this is where a patient is received by the OT staff. Then you have clean zone. So it's a pre-operating room. Examination of the patient and everything will take place here. Recovery room. Sometimes if in some hospitals, the shaving of the surgical site, removing the hair from the surgical site is done on the OT table. In some hospitals, it's not the policy. It has to be done in the clean zone, and then the patient is brought into the sterile zone for the surgery. So it depends upon how the clean zone is used. X-ray room, plaster room, sister's room, the break room, etc., anesthesia, store room. All these rooms will come under the clean zone. Your sterile supplies will be kept in the clean zone. From the clean zone, the sterile supplies will be moved into the surgical room, operation room. Sterile zone, this zone will include operating room, in particular scrub room, where hand washing and everything is done, surgical hand washing and everything is done. Instruments are also cleaned here. The anesthesia room, instruments trolley area. And finally, you have a disposal zone that includes the biomedical waste management policies and protocols. It will include a dirty room, disposal corridor, and janitor's corridor. So that was about the zones. Now we will move to the staffing of OT. So staffs in the OT, they are the main, the first goes to the surgeon. Okay, depending upon the facilities which the hospital has. There are certain staffing in OT in a district hospital, some beds, some tables are given. You can just read through it. Okay, so surgeons, anesthesiologists, nurses, technician, and attendants of the OT. These are the main OT team. How many number of surgeons, number of nurses and anesthesiologists you require, it depends upon the type of hospital you have, what is the staff complement in your hospital, specialty of the hospital depends on that. Policies of procedure and procedures, administration of the OT. So OT management is like you should be have a perfect team here, because when you are doing an operation, you are doing it without moving for a long hours, and you are doing an operation with a team of nurses, scrub nurses, anesthesiologists, technicians, and everyone. So the team management, it should be disciplined, and each one of them should have self-motivated high degree of acceptance which they want to follow. So to protect themselves as well as to protect the patient who is on table. Then OT scheduling, it should be a perfect planning should be done. There should be no wastage of time between two operations. As I have mentioned earlier, when you complete one scheduled operation by 9 a.m., how soon will be the OT be ready for the second elective surgery or any emergency surgery if in case. Okay, so that's the OT scheduling. How soon the OT operation room is ready to receive the next patient, because it has to be continuously running so that it maintains the profit for the hospital. Then punctuality, if an operation is scheduled at 9 a.m., it should all the equipments required for that particular operation should be ready by 9 a.m. Even if there is even if the patient goes into some complication, you have to delay the surgery by few hours, doesn't matter. But if it has stated that by 9 a.m. The surgery will start, before 9 a.m. the instruments, equipments, all the sterile articles, trolley, especially for that particular surgery, should be ready by 9 a.m. Then training of staff, especially training the staff in maintenance of excessive universal precautions. They should know the barrier precautions, using personal protective equipments, surgical hand washing, medical hand washing, the difference between that, the 5 moments of hand washing. Okay, all these training has to be provided to all the patient, all the staff, and they are also taught the no touch technique, which actually means that even if you're changing the dressing of a patient, you make sure you just change the dressing even without touching the wound or without touching the patient. So that's like a no touch technique, not just in changing the dressing, but whatever procedure you're doing on a patient where there are chances of contact, you minimize the contact as much as possible. You try to avoid contact as much as possible. That's a no touch technique. Then you have operating list, that is the list of equipments, trolleys, and all the articles and instruments which is required for that surgery. It should be ready in advance so that perfect time management is done. Then you have dirty cases, as I have told earlier, all the septic cases. These cases should be handled at the last of the OT, or there should be a separate OT to handle the septic cases. If you are a tertiary hospital, you can afford to have a separate OT just only for contaminated and septic cases. And this OT must be cleaned and disinfected after the procedure. And usually septic cases are performed last. So after disinfection, fogging and everything, then the OT is ready to receive another patient. Monitoring of asepsis, time schedule of maintenance of OT, make sure the swabs are collected from the AC ducts from the environment of the OT. It is regularly sent for culture analysis, etc. Wherever possible, HEPA filters should be used. Temperature control, humidity control, air pressure control, proper ventilation. These should be under the checklist, on daily checklist. And disinfection of equipment, OT table, other articles of the OT on regular time, scheduled time, it should be done. Fumigation is done. Fumigation is based on the square area of the OT. Those tables are given in page number 256. Like if the space is 1,000 square feet in area, 200 ml of fogging chemical is used in 800 ml water, and the duration of fogging is 20 minutes. That table is given. You can just go through that table so you can understand. It depends upon the surface area of the entire OT. You have to make the dilution accordingly. So that's about fogging and monitoring of assessors. Thank you.